This video is dedicated to ulnar nerve, one of the branches of the brachial plexus that we are exploring with a great level of details that are added to description of individual nerves arising from the brachial plexus. So I suggest that we again quickly review what the ulnar nerve looks like in some kind of very cut and dry theory, and we will move on to Netter's images and to get more detailed information about this nerve. Images waiting for us, but we're going temporarily first onto the whiteboard. The ulnar nerve is made solely by the medial cord of the brachial plexus. Fibers it carries are C8 and T1, which is perhaps a little bit of surprise, but along the same line you have the axillary nerve, which also has not been particularly rich, being only composed of C5 and C6. So C8 and T1 are fibers that the ulnar nerve receives, and of course, moment we start following it, we're going to find the nerve passing together with the brachial artery and, of course, with the median nerve on the medial side of the arm within so-called medial bicipital groove. Okay, at this point, the nerve does have one very quick rendezvous with almost like entire body surface. That is the medial side of the elbow, where ulnar nerve must pass through its own groove, sulcus nervi ulnaris, that is found inferior to the medial epicondyle of the humerus. In English-speaking countries, this is what people refer to as funny bone, with assumption that it was because someone didn't know really what the humerus is, but rather thought it was some kind of humor, and hence the funny bone term pretty much stayed forever, I would say, in English. So that is funny bone, and as I always say, it might look funny only to people who observe the poor person who hit their elbow quite hard, and there is much fun for them to enjoy. So at this point, really, like, why is nerve so sensitive? Because it is barely covered with a bit of skin, which is quite loose in order to allow us to do full flexion of the elbow, and a little bit of subcutaneous tissue, so any kind of direct hit, it could be quite mild, it could be quite moderate, will be immediately perceived as something that has unusually different sensation. So even if you gently tap in around the area of medial epicondyle, right away you're going to start feeling and experiencing a little bit of tingling sensation or some kind of electrical discharge, which most of the time you will be experiencing in, of course, little finger and ring finger. Why do I say most of the time? Because that is what your patients will likely be presenting, saying, hey, I have some issues, some kind of pins and needles in my ring and little finger. And of course, that moment you hear ring and little finger, you can start doing a little bit of further exploration, testing sensation on both sides of the ring finger, which likely will make your patient think, whoa, I didn't know, but this side I feel good, this one is still kind of numb. And of course, like, median and ulnar nerve tend to overlap a little bit, and that's why it's not always crystal clear presentation by patients, but it is due to a health provider to take a good physical exam to test the sensation on both sides of the ring finger before determining is it ulnar nerve which is ultimately involved. So at this point, the nerve runs pretty much protected by anterior forearm musculature, and then it arrives at the wrist. The poor median nerve didn't have any option. It had to pass directly through the carpal tunnel, squeezed with 9 different tendons in their tendon sheath. It is the ulnar nerve which runs superficial to the transverse carpal ligament, but by saying superficial, it doesn't come directly under skin. Ulnar nerve already had its near skin exposure, and it did not feel too good when bumping the elbow. And of course, the wrist could be quite more frequently prone to some kind of, I don't want to call them even injuries or accidents, but just not too gentle use of our own hands. So the ulnar nerve, while passing superficial to transverse carpal ligament or retinaculum flexorum, actually has a small, tiny compartment of its own within the transverse carpal tunnel, within the retinaculum flexorum. That canal is called canal of Guyon, Guyon. Canal of Guyon is found more laterally relative to pisiform bone. So if you palpate your own pisiform, you go laterally, it's here. This is where canal of Guyon is. And together with ulnar nerve, canal of Guyon will also be a good host for the ulnar artery. So regardless of being fairly close to the skin, the transverse carpal ligament and canal of Guyon appear to provide quite good protection for these two structures, ulnar nerve, ulnar artery, because even as children, we used to fall quite regularly. Most of the falls, we would be falling directly onto our outstretched hands or arms, practically sometimes even sustaining a minor skin injury around the wrist, but fortunately with no consequences for the ulnar nerve or ulnar artery or both of them. At that point, ulnar nerve came into the palm, so its main trunk will look like it's following into the direction of hypothenar, but then it'll start arcing around and will go towards lateral side of the hand. Ulnar nerve is going to be quite busy. It will innervate all of the muscles of hypothenar. It will innervate all the dorsal interossei, all the palmar interossei, then two medial lumbricals, and very importantly, it will innervate one muscle that is practically the only thumb abductor. Adductor, sorry, I said abductor, but I really meant adductor. So if you need to pinch something between your thumb and index finger or middle finger or ring finger or even little finger, you really have to have this muscle quite ready for action. Sometimes when people have injury to ulnar nerve, first thing that they may notice is that they do not have good grip as they're trying to pinch something. In one of the common episodes that they would experience will be holding a key, inserting it into a lock, but then unable to hold while turning to lock the door or unlock. So that is adductor pollicis muscle, which is quite close to the thumb, which is also functionally related to the thumb, but it is innervated by the ulnar nerve. Why don't we take a look at images from the Netter's Atlas and conclude our studies of the ulnar nerve. Here it is. I haven't been thinking about any illustration that positions the nerve within the medial bicipital groove. That is something that we already know. And this is sulcus nervi ulnaris, inferior to the medial epicondyle. As you can see here, once it has passed this kind of tricky, funny bone spot, the nerve runs protected by flexor carpi ulnaris, nerve is deep to it, and further deep to the nerve is flexor digitorum superficialis muscle. Keep in mind, flexor digitorum superficialis is median nerve, flexor digitorum profundus is innervated by both median and ulnar nerve. Medial half is what needs to receive ulnar nerve innervation, and it produces tendons that go into fingers 4 and 5. Following it quickly down to the level of wrist, this is the pisiform bone, this is the transverse carpal ligament, and this tunnel that we have is canal of Guyon. Pity that this diagram doesn't include also ulnar artery, but maybe it would be just one item too many for us to observe. I'll just briefly adjust the camera so that we see the lower part of the screen. where, as I mentioned, main trunk of the nerve looks like it is running parallel to the fifth metacarpal bone, but then the nerve just starts arcing across the palm, and this is where it gives multiple branches that are innervating those muscles of the hypothenar, dorsal and palmar interossei, and two lateral lumbrical muscles with, of course, a very important muscle that needs to receive also ulnar nerve innervation, adductor pollicis. Sensory signals from the hand are going to be pretty much complementary to what has been left for ulnar nerve after the median nerve took care of 3.5 fingers. Ulnar nerve covers ulnar side of the palm, and then it covers in its entirety ulnar half or medial half of the ring finger and the entire, of course, little finger digitus minimus. Not only from the anterior side of the palm, practically the similar distribution of sensory fibers is observed on the posterior side of the hand, and of course, two digits, number 4, number 5. Ulnar nerve, unfortunately, could be damaged, and as a result of its damage, basically it's the muscles that are paying the price for nerve injury consequences. It relates really where the injury is located. If the nerve is injured, let's say accidentally somewhere within the armpit, then it means distal to the point of injury. There will be some kind of losses. If a nerve becomes injured at the wrist, basically muscles that are again distal to the point of injury are going to be suffering. Therefore, the level of lesion is always in very much sync with where exact problem started appearing. Now, regardless of whereabouts we're having injury to the ulnar nerve, let's say it was at the wrist. So, function of flexor digitorum profundus and flexor carpi ulnaris may stay intact. So there should be no problems in wrist flexion, and of course, patient will be able to voluntarily flex not just proximal but also distal interphalangeal joints of fingers 4 and 5. However, if there is a problem, muscles that are intrinsic muscles of the hand would be the most severely affected. And as a result of this type of injury, we have a condition which is known as the claw hand. Claw hand deformity. It mostly affects fingers 4 and 5 because two lumbrical muscles that are part of mechanism that move index and middle finger, they're innervated by median nerve. And of course, we're talking here about ulnar nerve injury, which affects dorsal interossei, palmar interossei, and two medial lumbrical muscles. So if you just add what you know about them, interossei, lumbricals, they become part of the extensor hood. So as they come from inside the palm, passing of their tendon before merging with the rest of the extensor hood is happening that the tendon is observed anterior to the metacarpophalangeal joints. Therefore, lumbrical muscle will flex the finger at its knuckle. Right now I'm moving the ring finger, but the same could be done with index, middle, ring, as well as little finger. So independent flexion at knuckles while keeping fingers pretty much straight, fully extended at interphalangeal joints. So when function of these muscles is lost, it is going to result in some kind of reversal. That is how we see the claw hand. Those metacarpophalangeal joints will look like they're overextended. Why? Because we have extensor digitorum muscle coming from the posterior forearm innervated by a radial nerve. It naturally tends to extend fingers and it is quite successfully doing it at the knuckle, because the knuckle is not opposed any longer by flexor muscles coming from inside the palm, primarily lumbricals, but also interossei. That's why the ring and little finger are overextended. Loss of the interossei as well as lumbricals practically reduces the force applied to dorsal hood or extensor mechanism, which means we're lacking two important muscles that would effectively contribute to our ability to voluntarily extend fingers, because these muscles are paralyzed. Basically, the dominance on the anterior side of the forearm of flexor digitorum profundus, flexor digitorum superficialis are going to affect this. Depending on the level of ulnar nerve injury, we could have also a little bit more pronounced uh, paralysis when it comes to movement of ring and little finger, because it could also create partial paralysis of flexor digitorum profundus. But in order to explain what the claw hand deformity is, I was using mostly the idea about ulnar nerve being injured somewhere in the wrist region. Did not involve flexor carpi ulnaris and flexor digitorum profundus. So I think that this would be just, again, enough for us to go through details about the ulnar nerve. So that is third out of 5 branches. Radial and axillary nerve are remaining for us to cover them. So try to find them on the playlist. I will put them all together. Thank you for watching Anatomy Made Simple by Dr. T. See you in hopefully a couple of minutes and in the next part of individual nerves of the brachial plexus. Thank you.